The following podcast is part of a certified educational activity titled Improving Outcomes in Uncontrolled Moderate to Severe Asthma, Choosing the Right Treatment for the Right Patient. Access the entire activity and complete the post-test at peerview.com/EPJ860. Downloadable slides and practice aids are also available.
Welcome and good day. We're going to be talking about the pathophysiology of uncontrolled moderate to severe asthma, phenotypes, and their implications for treatment. My name is Reno Panettiere. I'm Vice Chancellor for Translational Medicine and Science at Rutgers University in New Brunswick, New Jersey. Now, as we think of controlled moderate to severe asthma, this has incredible impact on the quality of life. And when we're talking about that, we're talking about excessive symptoms, impaired lung function, frequent and life-threatening exacerbations, increased morbidity, comorbidities, high requirements for pharmacologic treatment. It poses a very significant economic burden, and that's shown in this slide. As we look at all-cause mortality, the greatest is seen in severe eosinophilic asthma. And if we now drill down to asthma-related economic costs, 2012 or even 2013, the number one most prominent cost is seen in the severe eosinophilic asthma as compared to severe uncontrolled asthma. Takeaway, eosinophilic controlled asthma costs a tremendous amount of money. Now, the uncontrolled moderate to severe asthma occurs despite standard therapy with inhaled medications. 5 to 10% of patients with asthma are considered to have uncontrolled asthma, while 70% of adult patients with asthma have type 2, T2 high, and or eosinophilic asthma is determined by greater than or equal to 150 cells per microliter. Now, many of these patients are dependent on OCS or oral corticosteroids, which then has consequences long-term with severe adverse effects. As we think of uncontrolled moderate to severe asthma, 54% of patients with severe asthma have greater than or equal to 3 exacerbations per year as disease severity worsens. 5% of patients with mild asthma, 13% with moderate. And important predictors of future exacerbations is an exacerbation within the past year. Degree of asthma control, asthma severity, T2 inflammation. These are all predictors of future exacerbations. Now let's drill down into the T2 high asthma, most often associated with an immediate IgE-mediated allergic reactions, eosinophilic inflammation, response to corticosteroids. T2 high asthma has a strong family history of atopic disease. This is early onset. We're talking about pre-adolescents. These are the patients who are mostly atopic with an allergic asthma phenotype. Overlap with other comorbid atopic conditions. We think of allergic rhinitis, atopic dermatitis. Early onset allergic asthma can present with mild to severe disease. Unclear whether mild allergic asthma progresses to severe disease or whether severe allergic asthma arises in childhood and remains severe, can be clearly exacerbated by obesity. Now, let's talk about that later onset, often age 20 years or later eosinophilic phenotype. Now, this is an interesting group of patients. This T2 high asthma patient, about 50% of asthma, is associated with high eosinophils. That is 2% or greater in sputum, no consistent serum level. In severe asthma, high numbers of eosinophils can persist despite inhaled corticosteroids and appear to be consistent over greater than or equal to 5 years. Lesser allergic basis, less related to family history, usually severe from outset, and can be related to sinus disease, polyp formation, aspirin sensitivity. This too can be exacerbated with obesity. So in sum, early onset asthma, these are the patients who are going to be more allergic, have little less frequent nasal polyps or chronic rhinosinusitis. Later onset, talking about often greater than 20, these are the patients who clearly have this nasal polyp chronic rhinosinusitis effect. Both of these can be exacerbated by obesity. Now, this is a busy slide, but it's an important slide conceptually. We're looking at two aspects of the pathophysiology of T2 high asthma. On the left is the classic allergic asthma driven by an allergen, recognized by dendritic cells, that then carry that allergen to local lymph nodes and induce a CD4 T cell production and proliferation. Now these cells then secrete IL-4, IL-13, and IL-9. IL-9 modulating mast cells. The B cells in response to 4 and 13 secrete now specific IgE. Now notice though, these cells also induce secretion of IL-5, and that IL-5 is absolutely necessary for the survival and the circulation and migration of eosinophils. 13, by the way, can directly affect airway smooth muscle hyperresponsiveness. So this pathway, which we're very familiar with, is the classic atopic allergen-driven pathway. Now let's look at the other side of the coin. This is the pollutants, the microbes, glycolipids that then activate epithelium to secrete alarmins. Alarmins are the IL-33, IL-25 TSLP molecules. Now these molecules will directly affect the ILC2 cells. These ILC2 cells then get induced to secrete IL-5, remember, that's the survival factor for the eosinophils, and IL-13, which directly impacts on airway smooth muscle function. So we can see that these two pathways, though distinct, are integrated into an eosinophil modulation of function, which then can also modulate the airway smooth muscle. These two pathways are critical as we think through the T2 high asthma phenotype. Now, the non-T2 Th2 asthma likely represents a large population of all asthma, up to 50% of steroid-naive patients. But little is understood about the phenotypes or endotypes of this group of patients. We do know it responds poorly to corticosteroid therapy. Linkage to obesity has clearly been demonstrated. And neutrophilic asthma may be driven by steroid use, associated with lower lung function, more air trapping, and thicker airways. Associations also present with infections, environmental exposures, ozone, and pollutants. Now, I have seen many patients with T2 high asthma, and the one that comes to mind most notably is actually a patient who is 52 years old, presented to me with uncontrolled asthma. She had clear atopic disease with multiple specific IgEs positive and a total IgE level that was quite elevated. She had an FEV1, a 65% predicted. And despite management with high-dose inhaled corticosteroids and long-acting bronchodilator therapies, she still required three tapers of prednisone a year. Now, fortunately, she didn't end up in an emergency room or a hospital, but I was most concerned with the uncontrolled nature of her asthma. In an atopic T2 high patient, her EOs, by the way, were 400, and she had comorbidity of nasal polyps and chronic rhinosinusitis. Altogether, she was a classic T2 high, later in life onset asthmatic, uncontrolled. So let's now talk about selecting the appropriate treatment for patients with uncontrolled moderate to severe asthma. Well, in order to do that, we have to determine asthma control. And in this slide, we really describe asthma control in patients with greater than or equal to 12 years of age. Components of control, and then characterizing them as not well controlled and poorly controlled. Symptoms, nocturnal awakenings, interference for quality of life, rescue inhaler use, objective measures of airflow FEV1, and valid patient-reported outcome questionnaires should be used as monikers of whether a patient is well controlled, not well controlled, or very poorly controlled. And here we summarize the not well controlled patients. As symptoms increase, as nocturnal awakenings are more frequent, as the patient is limited, they're either not well controlled, and at the extreme, the symptoms are occurring daily. Nocturnal awakenings greater than or equal to 4 times a week, extremely limited quality of life functional status. Using rescue inhalers every day and FEV1s less than 60% are the very poorly controlled patients. Now, I personally like the ACT test, the asthma control test. 5 questions, total score of 25 is as 100%. Here at 15, less than or equal, you're really talking about a very poorly controlled patient who is markedly affected. So why is this even important? Because these are predictors of exacerbations. These patients with not well controlled or very poorly controlled asthma are going to have greater than or equal to 2 exacerbations, and as a consequence, have substantial oral corticosteroid use. Now, the ATS-ERS task force in 2014 really codified a definition of severe asthma, and that asthma requires treatment, guideline-suggested medications, and fits the criteria of GINA steps 4 and 5. That is high-dose ICS and another controller for the prior year, or systemic corticosteroids with greater than or equal to 50% in the previous year. Now, to prevent it becoming uncontrolled or remains controlled despite therapy. So what we're really talking about is uncontrolled or controlled but requiring a substantial amount of medications. Now, what are the characteristics of poor controlled asthma? Greater than 2 OCS, oral corticosteroid requiring exacerbations in a year. Serious exacerbations are hospitalization and ICU visit or mechanical ventilation in the previous year, and or persistent airflow obstruction of an FEV1 less than 80%. These are the characteristics you need to keep in mind when you're talking to the patient with severe uncontrolled asthma. So how do we then manage this patient? First and foremost, is this asthma? We need to confirm the asthma diagnosis. History, physical, spirometry, reversibility, maybe a chest x-ray, and always address medication adherence. Is this asthma? Confirm severe asthma, maybe by using a body box plethysmography and a diffusing capacity to rule out other causes. Potentially methacholine challenge is necessary, but in all patients, I would highly recommend a blood eosinophil count, a total IgE, and specific IgE. Now, in some instances, a high-resolution CT scan offers opportunity to characterize comorbidity or identify other aspects that could be impacting the asthma. And treatment guidelines need to be adhered to. Now, what is contributing to the asthma? That's the next important question. Assess and manage comorbidities. Is the patient atopic? Now, we would know that from the total serum IgE and specific IgE. Does the patient have concomitant ABPA, allergic bronchopulmonary aspergillosis? Chronic sinusitis, very important. Is the patient a smoker? A smoking asthmatic occurs 30% in the US population, and those patients are less responsive to steroids. So at that point, maybe additional workup's necessary, potentially a referral to another specialist, an ENT doctor, or to the allergist from a pulmonologist, or a pulmonologist to the allergist, and look for novel investigational interactions. So what are the most common reasons for poorly controlled asthma? 1, medication uses, and we're talking about adherence or poor inhaler technique. 2, comorbidities. Here, nasal polyps, GERD or gastroesophageal reflux, vocal cord dysfunction can play a role in inducing a phenotype of poorly controlled asthma. And life cycle, we're talking about obesity, smoking, occupation, or an inability to remediate triggers, such as pets in the house. Now, identifying and addressing the modifiable causes of asthma control is important. Non-adherence. Now, in this case, non-adherence could be driven by simply the patient is not using the medicine, but there's often reasons for non-adherence, let's be honest. And those reasons are maybe the medications are truly not working. In that case, a shared decision-making among the providers and the patient is critical. What are the challenges? What are the difficulties in adherence? Is it access to medication? Is it the frequency doesn't match the lifestyle of the patient? These are the important questions to ask. Now, incorrect inhaler technique is a common complicating factor in asthma control. We, at almost every visit or every other visit, revisit inhaler technique. Errors need to be identified and corrected. If a patient's using an MDI, then potentially a spacer can mitigate some of the inhaler technique challenges. If we look at the GINA guidelines, and that's shown here, these are classically described as step 1 through step 5. And as the patient's asthma is more severe, there's an addition of more medications or an enhancement of the medications. Now, in step 4 and 5, we're really talking about a patient's asthma that is difficult to manage, requiring high-dose ICS, inhaled corticosteroids, or long-acting bronchodilators. And it's at this point where we're looking for alternative approaches or additional approaches. Here we're talking about biologics and tiotropium. By and large, relievers need to be prescribed across the board, very important. Remember that step 4 and step 5 patient, going and hearkening back to my first slide, are the ones that drive healthcare costs, the ones that have the poorest quality of life. Now, understanding disease mechanisms clearly now guide precision therapy in a personalized approach. We came in the 1970s and 80s with a one-size-fits-all mentality. We then developed stratified medicines, looking for clusters of attributes that defined each patient. Now we're in a new era, an exciting era. This era of personalized medicine drives home the concept: right medicine for the right patient at the right time. This is precision medicine, and we are now in that world of precision medicine for GINA 4-5 patients. So what are the biomarkers that really define this precision approach? Well, the biomarkers are shown here, and I really would suggest these measured prominently, as frequently as possible, longitudinally, to define whether the patient is doing well. Now, FeNO, or the fractionated exhaled nitric oxide is an important biomarker of T2 inflammation. High FeNO levels, measured in parts per billion, is a clear indication of an IL-13, IL-4 mediated epithelial cell inflammatory response. Blood eosinophils need to be measured. Higher the eosinophils, the more likely the patient is a T2 pathway patient, and that activation can induce the symptoms and signs that we described. Total IgE, and more importantly, the specific IgE frequency of the positive tests clearly define an atopic patient. Now, there are other biomarkers that are investigational, like urinary LTE4 and periostin. Neither of these are available to you as a practitioner. Takeaway here is FeNO characterizes a T2 high patient with an epithelial-driven signature. The blood eosinophils being elevated is a clear indication of an eosinophilic phenotype. Now, patients are complicated, and patients may have eosinophilic-driven T2 disease, they may have allergic disease, or they could have eosinophilic and allergic. There's other possible biomarkers in the future. Some of these are related to eosinophil activation, like eosinophil peroxidase. We're going to hear more about those, hopefully, but they're currently not available to the practitioner. Let's talk about targeted treatment options for uncontrolled asthma. Here we're going to talk about omalizumab, or an anti-IgE. Now, this particular drug affects mast cell and basophil activation. It affects any cell that has an Fc epsilon receptor. It's 3 milligrams per kilogram, given sub-Q every 4 weeks, and it's based on IgE level dose. The dose is based on IgE level and the BMI. It's approved for patients aged greater than or equal to 6 years with moderate to severe persistent asthma, and it is most effective in patients with a robust type 2 signature. Response is shown to remain stable over 60 months. Lung control quality of life has improved, and most importantly, exacerbations, hospitalizations, colds in children, OCS use and ICS use is diminished. Omalizumab has been around for 17 years. We have tremendous experience in this drug. Now, where is it really effective? Well, look for the T2 signature. Here we're using the T2 signature, blood eosinophils, and it's partitioned by greater than or equal to 200, greater than or equal to 300, greater than or equal to 400. On the ordinate is the reduction in the exacerbation rate. So the bigger downward square, the better the response. And you can see as eosinophil levels go up in the blood, there's a greater response. That is reduction in exacerbation rate. So how does that fit across the board? Well, here we're looking at patients with less than or greater than or equal to 300, history of emergency visit, asthma therapy, hospitalizations, FEV1, improvement, beclomethasone dose, and LABA use. And what you can see in the reduction in exacerbation rates is a substantial effect of omalizumab as the disease severity gets greater. For example, let's take a look at hospitalizations. There's almost a doubling. Actually, in fact, there's greater than a doubling in the decline in hospitalizations, a clear marker for more severe patients who received omalizumab. So what's the takeaway? The takeaway is the worse you are, the better you get in the case of omalizumab. Now, targeted treatments that now will address high eosinophils are the anti-IL-5 drugs. Here I'm going to speak of mepolizumab. Mepolizumab was the first anti-IL-5 that was approved in the US. It's administered 100 milligrams sub-Q once every 4 weeks. It's approved for patients greater than or equal to 6 years with severe asthma and an eosinophilic phenotype. Trials included patients with blood EOs down to or equal to 150, effective regardless of atopic status, and in the long term, studies have shown that the AEs are very similar to placebo. So what did it do? Mepolizumab improves lung function, measured by the FEV1, improved asthma control, quality of life, activity, and work productivity, while diminishing exacerbations, including those requiring ED visits, hospitalizations, and it's steroid sparing. OCS dose could be decreased as well as symptoms. Here, in one of the pivotal trial studies, we're looking at mepolizumab that was delivered in a placebo double-blinded manner at a low dose, 75 or 100. Now, the 100 is the one that is actually approved in the US sub-Q. 75 was delivered IV. If we look at the cumulative number of exacerbations on the ordinate, the y-axis, versus the time, and this was a little greater than a half-year study, placebo is the blue line, and you can see in both the 75 IV, the 100 sub-Q, that there was a substantial decrease in the numbers of exacerbations in this phase 3 Mensa study. So let's move on to another anti-IL-5, Rezolizumab. Rezolizumab is given on a weight-based approach and exclusively by IV. This is the only formulation that is given IV. It's 3 milligrams per kilogram every 4 weeks over 20 to 50 minutes. It's approved for patients greater than or equal to 18 years with severe asthma with an eosinophil phenotype, and trials were pre-specified for greater than 400 eosinophils. Now, effective regardless of atopic status. Now, we saw that with mepolizumab too. Isn't it interesting that these drugs can partition patients with an eosinophilic T2 high versus an allergic? They work in both instances. AEs are similar to placebo. There is a boxed warning about anaphylaxis. There's no data on OCS-Sparing. So what did Rezolizumab do? It improved lung function, improved asthma control and quality of life while diminishing exacerbations, including ED visits, hospitalizations, and oral corticosteroid dosing. Symptoms also improved. Here in these data, we're looking at the change in FEV1 versus the change in quality of life. And this is really important for this entire class of drugs. At the first observation, here 4 weeks, notice a substantial, almost doubling or greater than doubling of the change in the FEV1 over placebo. That is, patients with Rezolizumab had approximately a 200 ml change in the FEV1 at first observation, 4 weeks after dosing, in comparison to the placebo that had about a 75 ml change. And that was hearkened over the entire 52 weeks, the entire year with that change. Now, if we look at quality of life score improved and again was sustained over the full period of time. So in that case, the higher the number in the AQLQ is the better the score. So let's move on to the last of the anti-IL-5s that have been approved, and this is Benralizumab. Now, Benralizumab is a 30 milligram dose sub-Q every 4 weeks for the first 3 doses and then converts to 8 weeks thereafter. It's approved for patients greater than or equal to 12 with severe asthma and an eosinophil phenotype. All the anti-IL-5s are targeting an eosinophil phenotype. Clinical trials studied all comers, but patients with greater than 300 did better. AEs, pretty modest, and looked just like placebo. The anti-IL-5 drugs, by and large, are incredibly safe and have low adverse effects. So what did Benralizumab do? It improved lung function, asthma control, quality of life, while diminishing exacerbations, sparing OCS, and improved symptoms. Now, Benralizumab's mechanism of action is unique. The others are ligand antibodies. In this case, it's a receptor antibody that then brings in natural killer cells to abrogate the eosinophil. If one looks at the exacerbation studies, and in this case, the registration studies were termed Soroka and Kalima, you can see in this slide that patients with greater than or equal to 300 in both studies had a dramatic reduction in exacerbations seen, and those are the two upper panels. In patients with less than 300, there was still a reduction, but not quite as robust. The takeaway, all the drugs in the anti-IL-5 category improve exacerbations, improve quality of life, and importantly, at first observation, improve the FEV1. Now there's yet another biologic, and an important biologic, in that this is a first-in-class and only-in-class anti-IL-4 alpha receptor. Now the anti-IL-4 receptor, or the IL-4 receptor, is important. It integrates signals from both 13 and 4. So if you block the IL-4 alpha receptor, you take out those activations of both 4 and 13. Now, the recommended dose here is 400 milligrams sub-Q, followed by 200 milligrams every other week. This is a every 2-week dosing. It's approved for patients aged greater than or equal to 12 years with moderate to severe asthma and an eosinophilic phenotype, or with OCS-dependent asthma. Clinical trials studied all comers, but those patients with greater than 300 EOs actually did a bit better. Now, this is not an anti-EO drug, but they clearly were a marker for success with Dupilumab. Now, the pheno can also be used in this case because remember what I mentioned before, the epithelium activated by 13 and 4 secretes more NO. So the higher the NO, that may be a signature for a T2 high patient who could be treated with a drug like Dupilumab. The AEs, very similar to placebo, quite modest, and really the only ones were injection site reactions. So what did this drug do? It improved lung control, asthma control, quality of life, while diminishing exacerbations. It spared oral corticosteroids and symptoms. In these data, on the left panel, you can see Dupilumab decreased by about 50% annual exacerbations. That was at the 200 and even the 300 dosing. On the right side, you can see the annual exacerbation rate with Dupilumab in the other studies, now looking at greater than or equal to 300. Parsing out the high EOs, and you can see with the high EOs, that's in the bottom panel there was a more robust signal with regard to annual exacerbations for both the 200 and the 300. So the takeaway, this only in class anti-IL-4 receptor antagonist decreases exacerbations, and it does it in a way that if you have higher EOs, there is a more robust response. So let's look at oral corticosteroid sparing. Now remember, this is one of the critical issues in difficult to manage asthma. OCS burden causes tremendous adverse effects. We see with omalizumab, mepolizumab, benralizumab, and Dupilumab, consistently biologics decrease oral corticosteroid need. We need to be shepherds as specialists or as providers in diminishing the use of oral corticosteroids. All of these drugs, except Benralizumab, have clearly shown OCS sparing. So let's talk about a possible treatment algorithm. That's shown here. For allergic asthma, without EOs, an anti-IgE would be optimal, or potentially an anti-IL-5 or an anti-IL-4/13 if allergic and eosinophilic. The allergic asthma with no eosinophils, maybe a low pheno, clearly an anti-IgE would be in order. And if you had an eosinophilic asthma and non-allergic or allergic with IgE out of the dosing range for an anti-IgE, in that case you may think of an anti-IL-5 or an anti-IL-4/13. OCS dependent, then an anti-IL-4, anti-IL-13 drug may be useful. Now, there has been no head-to-head studies as to whether one is better than the other. Other factors might be a shared decision-making approach. Ask the patient, what mode of delivery would be best? The frequency that they're comfortable with. It's the patient's comfort with self-administration. Many of these medicines are now being delivered in the home, the injection frequency and comorbidity. So what's an emerging agent? What might we see in the horizon in the next year or so? Well, the phase 2b studies of Dupilumab, anti-TSLP antibody, were quite encouraging. Here, across the board with dosing, you can see a dramatic effect on annual exacerbation rates. And on the right side, it didn't matter what the eosinophil count was. Now, remember where TSLP fits. TSLP is one of the alarmins secreted by epithelium, and it's very upstream from all the other pathways. So it's reasonable to believe that a Dupilumab focused specifically on that secreted TSLP protein upstream may modulate, regardless of eosinophil counts, outcomes. Okay, so let's go back to the patient that I presented, my patient. That patient, as you recall, had a high eosinophil count, about 400, and had substantial specific IgEs. That is, she was atopic. Now remember, she was difficult to manage because she required a lot of oral corticosteroids for exacerbations, had 2 of those, and her FEV1 was 60% predicted. So what did I do? In this case, in this patient, I started omalizumab, an anti-IgE, because her IgE level was high, and even as important or more important, her specific IgE levels were substantial. The good news in this patient is that upon therapy, over the ensuing 3 to 6 months, there was a dramatic decrease in her symptoms, a dramatic decrease in her need for oral corticosteroids, and importantly, she was exacerbation-free. So clearly, my patient benefited from a precision medicine approach using biomarkers to categorize the type of asthma, to use the right therapy for the right patient at the right time. So in summary, insights into the underlying pathophysiology of asthma has led to targeted precision treatment options. These therapies can significantly reduce exacerbations in asthma patients, especially those with severe disease. And selected agents can also improve asthma-related quality of life, asthma control, and pulmonary function. Above all, effective communication with patients and embracing a shared decision-making approach are essentials if we are to engage patients in their own care and improve outcomes.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/EPJ860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.